I do about this particular area. I spoke about substances, potentially abused substances in particular classes. And what, to be more specific, I was talking about the 5 abused drug schedules. There are schedules 1, 2, 3, 4, and 5. I didn't mean general drug classes like antidepressants and antipsychotics. I was talking about the schedules that were created by the DEA, the Drug Enforcement Agency. I don't remember the year, but it's in one of my other lectures. I think it was the late 70s. And they created 5 drug schedules, sometimes loosely called classes. The lower the number, the greater the potential for dependency and addiction. So class 1 are the illicit substances like heroin and cocaine. There are some exceptions for cocaine where it can be used legally, can be used as a hard palate anesthetic for glacial cancer. As a matter of fact, Sigmund Freud was actually addicted to cocaine for that reason. But he really didn't suffer from the effects of that addiction. But any event, it's interesting. But the higher the number, the lower the potential for abuse, but there's still some. So a class 5 would have the least potential for abuse. Most of the stimulants, the psychologically dependency-causing drugs, are either 2 or 4, as a rule. So that's just, so thank you for that. Anytime you want clarification, please ask. As far as neurophysiology and psychopharmacology concepts, now we get into the real nitty-gritty, and I hope it whets your appetite for my class, if I'll teach it in January. That's up to Bill Axe, I suppose, but we'll see, as we get into this in more detail. But again, to know about psychopharmacology, you have to know about neurophysiology, physiology of the nervous system. The nervous system is composed of the center, this is just an overview, the central nervous system and peripheral nervous system, okay? The central nervous system, in turn, the brain and the spinal cord. Central, everything, the nerves that lead out of the spinal cord, and for that matter, the brain, that's the peripheral nervous system. The neurons are the actively transmitting nerve cells. In other words, they transmit the action potentials, which are the bioelectric nerve impulses. In turn, the APs proceed unidirectionally along the neurons, mostly along their long axons. They enter the dendrites, pass through the cell body, and are transmitted along the long axons. Why do we have unidirectional activity in the nervous system? If we didn't, it would be like no traffic rules on the highways. Cars would be constantly bumping into each other, and there'd be no order, it would be chaos. So that's why we have unidirectional nerve signals. Synapse is incredibly important for patients on psychotropic medication. What are synapses? They're physical gaps between neurons. Between the neurons, the axons of a neuron, or the axons of neurons, and the dendrites, or cell bodies of subsequent neurons in the chain, they don't touch each other as a rule. There is actually microscopic gaps, and they're called synapses. Sometimes the gaps are between the last neuron in the chain, like the last efferent neuron away from the central nervous system, and the target organ cells like muscle fibers. So there's a gap at what's called the neuromuscular junction between the axon and the muscle fiber. Chemical transmission. There's bioelectric transmission down the dendrites, the cell bodies, and the axons. But there's chemical, by definition, chemical transmission through the synapse. you say to yourself, well, this is awfully why did we evolve this way? So isn't it unnecessarily complicated? In the Middle Ages, we used to think that we were just a set of wires. And that relates to neuroplasticity. You know, we're not a set of wires. It doesn't work that way. Synapses probably evolved because the synapses are where a great deal of the plasticity is. Synapses can be destroyed, new synapses can form, so we can rewire ourselves. That's what a good deal of neuroplasticity is all about. We rewire ourselves at the synapses, new connections between nerve cells. The neurotransmitters are the chemicals which transmit those nerve signals across the synaptic cleft. And on the side, neuromodulators, yes, they are neurotransmitters in a way, but they're called modulators because they're usually larger chemicals, larger protein molecules, which don't transmit the nerve signal, but they modify the transmission across the synapse. And the very important, now we get back to the receptor concept. Generally, neurotransmitters and neuromodulators must bind to receptor molecules to exert their effects. And the drugs which either antagonize them or agonize them bind to those receptors. So, does everything seem to be falling in place? The macromolecular receptors are located both on the presynaptic neuron, that's the neuron preceding the synapse, the presynaptic terminal, and the postsynaptic membrane, the neuron after the synapse. The molecules themselves are complex structures. They're usually lipoproteins or glycoproteins. We don't need to go into that. But at the synapses, activation of a postsynaptic receptor could be excitatory. In other words, increase the likelihood of an action potential in the postsynaptic neuron, or inhibitory, decrease the likelihood of an action potential. GABA and glycine, gamma-aminobutyric acid and glycine, two neurotransmitters in the brain, are almost always, really with GABA, always inhibitory. The other, glutamate, is almost always stimulatory or excitatory. The others, it all depends upon the receptor. The presynaptic receptors can trigger reuptake of the neurotransmitter into the presynaptic cell to be remetabolized. And it can do that several ways, either directly by serving as a neurotransmitter, either directly by serving as a transmembrane carrier protein, or by triggering the action of the transmembrane protein carrier. In other words, the presynaptic receptor may be the carrier itself, or the ligand binds to the receptor and it triggers the substance carried across the membrane. So, to further the concepts, neurotransmitters must be cleared from the synapse to preclude hyperexcitation of the postsynaptic neurons. And there are several mechanisms to clear those neurotransmitters. Presynaptic reuptake, as discussed, or enzyme degradation of the neurotransmitter at the postsynaptic receptor. So, to clear excess neurotransmitter, to preclude hyperexcitation, you either take the neurotransmitter back up in the neuron where it came from, and psychotropic drugs do. You heard of SSRIs, right, to fight depression, antidepressants? That's how SSRIs work. Selective serotonin reuptake inhibitors. They bind to a receptor on a presynaptic molecule, they actually inhibit the normal reuptake mechanism, which is meant to clear serotonin from the synapse. So more serotonin stays in the synapse, and that's been associated with alleviation of depression. The deficiency of serotonin has been associated with depression. Just be very careful of that, because the some companies a lot of money. But just be careful of that. It's not necessarily precise. It's more complex. An example of tweaking enzyme degradation, yes, there's normally enzyme degradation like by Mayo, monoamine oxidase. That, again, it doesn't only happen in China, it happens here too. But, all right. But monoamine oxidase is an enzyme that degrades neurotransmitters. It clears them from the synapse to prevent hyperexcitation. Mayo inhibitors inhibit, they serve as a ligand, a dummy ligand to that enzyme, to Mayo. They block the degradation, cause more neurotransmitter like serotonin or epinephrine to be in the synapse, and that helps alleviate, at least in theory, helps alleviate depression. So does that make sense?
Can I ask a quick question?
Yeah, sure.
So with the SSRIs and the possible drawbacks to using them, would you say it's better to do a natural alternative like a 5-HTP?
If it works, yes. The answer to that is if it works, yes. I mean, there's several natural serotonin stimulants. The most innocuous of which, unless you're lactose intolerant, is warm milk. Or turkey. They contain. That's why you fall asleep with a high amount of turkey or warm milk. It may not keep you asleep, but it triggers somnolence. The answer to that is if it works, yes. The more natural. I wish if I lectured before you went another class, I could go into more detail. I know there's a lot of questions about that. Several degrading enzymes. Mayo is one. Catechol-O-methyltransferase is another. Acetylcholinesterase is another. If it ends with ASC, it means it's an enzyme. The suffix ASC means enzyme, which are omnipresent in the acetylcholinesterase is very important because it's the only enzyme that degrades acetylcholine, which is responsible for triggering muscle contraction in the peripheral nervous system, and acetylcholinesterase pathways. In other words, central cells in the brain that make use of acetylcholine, their deterioration is implicated in Alzheimer's disease and other dementias. And again, a little bit, I already said this, but a little bit about medication classes. Drugs are generally either classified by what they do, like antidepressants. And this is, again, addresses Elena's question before. This is a general meaning of drug classes, not scheduled drugs, but or class drugs, but drug classes. What they do, antidepressants, how they work, their mechanism of action, like SSRIs, what they do. They inhibit reuptake of serotonin. Sometimes they're classified by their chemical structure, like the antipsychotics, the phenothiazines. And then there's subclasses, what type of phenothiazine. Drug classifications systems are not perfect. Meds from, as I gave an example before, meds from one class may cross over into another class. So beware that nothing that I know of in medicine is perfect. A perfect creature doesn't exist in any way, shape, or form. So this lecture basically gives you a general idea of what you will be working with when you work with professionals who deal, with medications and with direct physiology issues. The brain is what? The brain is just a physiological and anatomical organ. Yes, it contains the mind, but it's physiological and anatomical, and it fits in, I think, pretty nicely as a rule with the rest of the body. But always, always relate all this gobbledygook, I hope it's not gobbledygook now, but relate this to your clinical practice. If you don't do that, it's going to be lost. If you do that, you might be excited. And I just want to say, just have a couple of minutes, but I just want to say one thing. For those who viewed the live discussion on Tuesday, Dr. Neil Madrona said something which I found very interesting. He said that nowadays, medical professionals don't really distinguish between organic brain diseases or conditions and functional conditions. And I found that they call the terminology now is neurodegenerative cognitive deficit, which actually he's right, and I'm glad that's done. But this is what I wanted to point out, that even when they did, on a more prevalent basis, distinguish between organic and functional, it's a matter of degree. There is no black and white. It's a matter of degree. What they called organic was any time you were able to image a discrete lesion. You called it organic. It was organic. You imaged a discrete lesion. If you saw a discrete lesion, it was epilepsy, for example. Functional doesn't mean it's imaginary, nothing like that. Functional just means you observe an altered function, pathological function, but you can't observe a discrete lesion. It's a matter of degree, period. And I want to leave with one joke and one inspiring statement. This is actually, it's not really a joke. It really wasn't funny. Well, it was funny. It wasn't at the time. This is absolutely true from real life. I worked with my father for many years in a pharmacy in Greenwich Village, New York, in the West Village. Still there, C.O. Bigelow. It's still there. I think it was established in 1838. And we had an elderly pharmacist. He was an owner. He was one of the chief owners. And he had bad eyesight to begin with. It's absolutely true. He had bad eyesight, so he wore very thick glasses at that time. We were very nervous when he used to fill prescriptions. But very sadly, he had a stroke. So on top of his initial condition of bad eyesight, it's absolutely true, his judgment was affected by the stroke, and his eyesight got worse. We called him Uncle Willie. I can say it now. He's long gone. But his name was Willie Ginsburg. We called him Uncle Willie. And he was a very colorful character. He used to run around the store singing Beetle, Beetle, Die, Die. No one knew why, but he did. And it's a true story. And in any case, one day, after he had the stroke, my father and other pharmacists were very careful to supervise him, because he would make mistakes. Very careful to supervise. And you know, it's not like substituting chocolate ice cream for vanilla ice cream. If there's a mistake, unless you're allergic, big deal. But it could kill someone. So one day, and I saw the prescription actually, one day he filled a prescription which was meant to be something called Winstrol, which there is a new Winstrol, but this is a Winstrol that was discontinued a long time ago. It was a combination of conjugated estrogens and meprobamate, which is an anxiolytic for anxious and depressed perimenopausal women. So that's what it was supposed to be, Winstrol. If I saw the prescription, if you looked at it a little different way, it looked like Uracid, which is a urinary antiseptic which contains the dye methylene blue, which turns the urine blue. It's relatively harmless, but in any case. So you guessed it, Uncle Willie misread the prescription. He escaped supervision, and he filled the prescription. It was a refill prescription. He refilled it for Uracid. Well, the next day, and it was a nervous perimenopausal woman. Well, next day, this is true. This is absolutely true. God's honest true story. So he filled it. Next day, my father was on duty, and he get a frantic call from the wife. The one says, I don't know what to do, I think I'm dying. She says, my urine is turning blue, I think I'm dying. So my father asked her, okay, what did we, she said that, you know, it was a refill prescription, and the pill didn't look the same, but it was my name, the same doctor, so I took it anyway. So he's asked to describe the pill, and so he looked it up, and he realized right away what the issue was. Winstrol came in strains, and it had the strain. Yours said doesn't come in strains. So again, Uncle Willie's judgment was affected. So my father told a lie, which these days, it was a fib, a white lie, which these days you'd probably be sued for. But he said, don't worry. He said it's the same thing made by another company, but bring it back. We want to make sure you get the exact same thing you got at first. So she did, and luckily, this was not something that could kill her. This was actually something, turned the urine blue. It's urinary antiseptic, contains a little sedative. It was no big deal. But the wrong mistake, and it could kill someone. And very quickly, this I can do there was an even funnier thing that happened. And you'll get a real, it's late in the day, you'll get a real kick out of this. There was a pharmacist named, we called him Morty. He was a very stern Italian-American pharmacist. Real name is Pellegrino Mortellaro. And I hate this, but this is God's honest truth. He was a very stern, everything had to be exact in the pharmacy, but he had a penchant for pornography. He just had a penchant for pornography. And one day, the two things got mixed up in the pharmacy. What happened was he was very excited one day because he was telling his coworkers that I don't know how many you are old enough to remember, but that a judge I believe in Boston, overruled a censorship law and allowed the uncensored copies of the novel Fanny Hill to come in the United States from Europe. I think from France, if I remember correctly. So Morty was telling his co-workers that he ordered it and it's coming in and so forth. And I was like, well, he must have gotten distracted. Because there were no computers in pharmacies then, and he was typing a prescription label. And okay, so I'll leave it at that. And in any case, the next day the phone rings again, and one of his coworkers, Jack Rose, I'm still friendly with Jack, and actually Bill Axe met Jack. He came here, Jack came, and ironically, Bill and Jack were in the same area at the same time. Bill Axe had attended the New School for Social Research, and that was a couple of blocks from Bigelow's. So, in any event, so Jack answers the phone, and the woman says, "Excuse me, but I'd like to ask you something. I think I picked up the wrong prescription." She said the pills look exactly. It was a refill. The pills look the same. Said it's my name. It's the right doctor. No, I'm sorry. She said it's the right doctor. The pills look exactly the same. Everything is the same, except that it's for the wrong patient. Said it's for a patient named Fanny Hill. and then Jack had to put the phone on mute button because he fell down on the floor. He realized what happened. Morty was so obsessed with the novel Fanny Hill that he got carried away and typed Fanny Hill in the patient's name. It's absolutely true. And to conclude, I just want to conclude with something that my professor Lou Irwin said in Columbia University, and I'll never forget it. And that is, he said, biology, medicine in general, has found its Isaac Newton in Charles Darwin, but it's yet to find its Albert Einstein. Okay, I hope I didn't put all of you to sleep.
No.
Thank you.
Thanks, Sam. So, guys, don't forget to sign out when you leave, and we'll see you tomorrow morning.
Excuse me, Bob.
Yeah.
Yeah. Map out courses to the
Come and see me tomorrow morning. Yeah.
I'm going to take